Hi, my name is Louisiana Adinda Abraham Jacob, and I'm presenting a new hope for otosclerosis, more so the development of new stapes prosthesis. In regards to normal ear physiology prior to otosclerosis, it involves eardrum vibrations which are passed through three tiny bones in the middle ear. The ossicles then vibrate the sound, projecting sound waves to the inner ear and then the cochlea. Figure 1 shows the main structural components of the ear and the stapes, which is the primary focus of this presentation. Normal physiology versus otosclerosis. As auto means of the ear and sclerosis means hardening of the ear, this disease is primarily conductive hearing loss due to abnormal bone remodeling. Bone remodeling itself is a lifelong process in which bones replace old tissue with new tissue. However, in some cases, this can disrupt the ability of sound to travel from the middle ear to the inner ear. So what causes otosclerosis? When the stapes become stuck in place, this causes reduced sound movement, and the reasoning of this still remains unclear. Many have suggested this could be from stress fractures, immune system disorders, and measles in few cases. Figure 2 shows the basic anatomy in the smaller image, and then the larger image demonstrates otosclerosis affecting the ear. Stapedotomy is performed as an initial response to otosclerosis. This surgical procedure involves the removal of the original stapes, and it is replaced by an artificial device, consequently enabling sound waves to travel and be received. In Figure 3, this demonstrates the typical stapedotomy surgery. So what happens is the ear canal skin and eardrum are incised and then lifted in the top back area, and this is to expose the middle ear space, showing the incus and stapes. After some bone removal, the incus is then disconnected from the stapes, and through laser removal, the stapes is removed and a hole is made in its footplate, and this hole essentially acts as the foundation for the implant as shown in Figure 4. The implant is then placed into the footplate hole and then attached to the incus, and after this procedure is completed, the skin is draped back to its original position. As explained in the previous slide, stapedotomy requires the insertion of the prosthesis to stimulate the inner ear and restore hearing to a degree. It was found that post-op hearing results were generally successful. However, this was mainly for low to medium frequencies of 0.5 to 3 kHz. It was found that many sought after revision stapes surgery for higher frequencies as well. The new chamber stapes prosthesis is a functioning prototype designed in Poland in 2017. This new prosthesis mimicked the natural ear and transmitted vibrations for frequencies of 0.4 to 10 kHz, so wider than the range previously mentioned. This prototype was then implanted into the human temporal bone, and its success was assessed by vibration measurements. As shown by Figure 5, A was a design of the actual chamber stapes prosthesis. So 1 was a conical chamber filled with fluid, 2 was a flexible membrane, 3 was the rigid plate with an attachment, and this mimicked the actual stapes, and 4 was a thin capillary tube that connected the chamber with the vestibule and allowed fluid to flow. Figure 5b is just a photo of the actual chamber stapes prosthesis prototype filled with fluid. The new chamber stapes prosthesis aims to help patients with otosclerosis. The newly designed prosthesis mimics a stapes vestibule, and in comparison to previous types, this particular design is safer due to the absent requirement of a movable insertion. Their findings are also indicative of success as they demonstrate greater hearing results, especially for higher frequencies. As shown in Figure 6, this shows the new design volume displacement frequency in comparison to other types. So as you can see, the red dotted line, which represents the stapes prosthesis prototype, is much higher than the lowest black dotted line, which is a representation of a previous prosthesis. The new chamber stapes prosthesis will assist patients in their lifestyles by offering stapedotomy that optimizes higher frequencies, especially above 1.5 kHz. This particular design still maintains similar procedures of previous types, however is safer due to no requirement of a movable element into the vestibule. This prosthesis also restores cochlear macro mechanisms, meaning successful post-operative results can be expected. It is suggested that in future research that this prototype could be tested on a wider test population to see if this positive effect is across the board. With all this been said, developments in hearing technologies such as this are crucial to helping those with hearing difficulties whether genetic, acquired, or due to injury. Advancements such as the chamber stapes prosthesis are indicative of this positive advancement in physiological studies. These are my references, and thank you for watching.